or frontotemporal dementia, as well as Lewy body dementia, and there's several others that we won't talk about. So when a clinician sees somebody that they suspect of having dementia, they usually do a workup. And that workup involves a couple of different things. One is a history, and by history, we mean just asking people, how did this evolve? What are the specific symptoms? They might do a physical or neurological examination, brain imaging, some cognitive testing to sort of just get a sense of how someone is doing, how their memory is objectively. And then they might do some things such as like take blood or even take spinal fluid. So we're going to really focus on brain imaging. And we're going to focus on brain imaging both in the setting of how it's used clinically by different doctors to make the diagnosis of dementia and what specific type of dementia. But we're also going to emphasize brain imaging in the context of research, because without research, we really can't get a better handle on these diseases. I think our understanding of these diseases, even though we've made a lot of progress, is still pretty early. And I think it's still pretty much behind diseases in other parts of the body. And so we really have a lot of catching up to do to understand these diseases so that we can treat them and relieve the burden that they cause to people. So there's kind of two types of brain imaging that we usually talk about. You can oftentimes divide it into two types. One is structural brain imaging. And what I mean by that, and this is just showing a structural MRI, is a structural brain image is just a picture of the brain. So it's just a kind of static picture of the brain. Nothing's moving. You're just looking at sort of the anatomy. You're looking to see if there's changes. You can think about it like when you have chronic headaches and you tell your doctor, I've been having headaches a lot, they might order an MRI or a CAT scan of your brain to see if there's anything concerning like a brain tumor, or if there's a bleed in your brain or anything like that. It's just a picture of your brain. The contrast with that is something called functional brain imaging. And there are a couple of types of functional, actually there's more than a couple of types, but basically what functional brain imaging is it's looking at the function of the brain. So it's a little bit more like a movie of the brain in a sense. You're actually trying to get some kind of ascertainment of how the brain is actually working. So that could be something like where blood is flowing to different parts of the brain, or what parts of the brain are being activated by different tasks. So you could kind of, the classic example is you could show someone a very powerful visual stimulus, like a flashing light or a flashing checkerboard, and you can see that the sort of visual parts of the brain light up in that case. And so what I just described is an example of functional MRI, but you can also do a PET scan, which we're going to talk quite a bit about, to see the activity, the blood flow, the metabolism of the brain, where certain chemicals in the brain are being concentrated, so on and so forth. So let's first talk about MRI. And MRI, what that stands for is magnetic resonance imaging. And so what happens when you get an MRI? Many of you have had an MRI, so you already know. We're talking specifically about MRIs of your brain, but you can also get MRIs, of course, as you know, of your knee and other parts. So when you get an MRI, you get oftentimes changed into this hospital gown, and then you lay flat on a table just like this. This is a Siemens MRI machine. And then you are basically slid into the center of this kind of donut hole. You have earplugs placed because the MRI can get very loud and noisy. And the MRI, as those of you who have had MRIs know, can be a very tight space. So it can be a little bit claustrophobic. But you're slid into the center of it. Your legs are hanging out of the machine, but your head is actually inside of this kind of donut hole. And then the machine takes pictures usually for about anywhere from 30 to 45 minutes on average. And again, it is kind of loud, so they do give you earplugs or headphones. And they also place this kind of mask over your face. This is what's called a head coil, and that allows the actual machine to take pictures. One of the important things to remember about MRIs is that it uses a very powerful magnet. So one of the things that we screen people for very thoroughly is to make sure that they're not bringing any metal into the machine. So we want to make sure that they're not bringing like their car keys into the machine, not bringing their credit card into the machine, because that, would erase their credit card. And we also do a thorough examination to screen people to make sure that there's no metal in their body. Now, nowadays, a lot of the metal that people have in their body is still safe in an MRI machine, because MRIs just became so popular and so common that they became so common that surgeons, when they were doing like hip replacements and knee replacements and things like that, would use things like titanium and not use things that that the actual magnet would pull on. So many things are safe, but we're very, very careful to make sure that we don't introduce any metals near the machine, because they will be pulled really fast into the machine. But other than that, it's really a very safe procedure. So long as there's no metal in the environment, it's a really safe procedure. One of the important things to know about MRIs is that there's no radiation at all. There's no ionizing radiation that you're being exposed to. And so that means so long as you don't bring metal into the machine, you could get, a lot of these. You could get tens and tens or even hundreds of these MRIs, probably without any untoward effects to your health. So some of you might be interested to really talk about quickly how MRIs work. So I'm just going to really quickly go into that. So what happens in an MRI is that you are trying to excite these protons that are throughout your body. You have trillions and trillions of protons in your body. And so what happens is the MRI creates this really strong magnetic field. And the protons are sort of twirling around. They're oscillating. And then once that magnetic field is created, the protons will align their angles with that of the magnetic field. You then introduce what's called a radio frequency pulse, and that sort of disrupts the angle at which the protons are spinning. And then you take off the radio frequency pulse, and then the protons will want to spin back in the direction of the magnetic field. And as they're spinning back to that direction, as they align with the magnet again, they're going to release this electromagnetic energy that's detected by the machine. And different tissues in the brain are going to do this at different times and with different frequencies. And that's how you can actually detect what tissues are in the brain and where they are in the brain. So this is just an example of, what we called a structural scan, a structural brain image. And these are examples of a structural MRI. And when neurologists do structural MRIs, and when they're looking at people to see, if they may have dementia, one of the things they're looking for the most is shrinkage of parts of the brain. And the fancy term for that is atrophy. So we're not really looking, when we look at an MRI, for like brain tumors. We're not really looking to see if there's blood in the brain necessarily, or to see if someone has multiple sclerosis. We're really looking to see if there is shrinkage in parts of the brain. Now, as we get older, our brains naturally shrink. So we always have to take that into account. We have to look at the age of the patient and say, for somebody that's X years old, is this part of the brain more shrunken, have more atrophy than it should? So on the left, you're going to see a brain of somebody that doesn't have dementia, that's cognitively unimpaired. And on the right, you're going to see the brain of somebody who has what's called frontotemporal dementia. And what that means is that they're going to have shrinkage in the front part of the brain. And to orient you, we're going to be looking at the brain as though it's someone's face that's looking out of the screen. So these would be the person's eyeballs here, and these would be that person's eyeballs. And so we're going to kind of go through these images starting at the very front and going all the way to the back of their head. So here we go. And you can see on the left that this is a normal, fully packed brain. And you can see here on the right that there's a lot of space in between the ridges of the brain. And these dark holes, which are the ventricles of the brain, have expanded. Everybody has these holes. Everybody has these little cavities in their brain. But in the person on the right, these have expanded so that you can actually see them get bigger, because the rest of the brain is starting to shrink. Okay. And so these are just still images, not the movie images, but the still images. Here you see on the left that all of these areas of the brain, which we call gyri, are nicely packed together. There's not a lot of space in between them. But over here on the right, hopefully you can appreciate that there's a lot more space here, which is represented as this black space. So what that means is that the gray areas, which is the brain, have shrunken, and they've been replaced by this kind of blackness, which is just fluid that's taken up that real estate because there's been shrinkage. And again, these are the cavities that I was talking about in the middle of the brain. Everybody has them, but here, the person on the left, they're nice and small. Here on the right, they've expanded because they're taking up the space that's left by the shrinkage on the outside of the brain. So how can we apply research to this? That's how some, a clinician might actually look at someone's brain and look for areas of shrinkage. But what research applications might we apply to this, and what might we do to examine shrinkage on an even more specific level and with even more specific tools? So we have these computer programs that can take an MRI image and do this computer processing and decide basically what's the gray matter of the brain, which is shown here in this kind of pinkish salmon color. What's the white matter of the brain, shown here in white? What are the structures inside, deep inside the brain, which are shown here in green? These are the cavities I was talking about in purple. So it's a really cool program where you just kind of put this brain image in and it automatically labels all of these structures. And then it also can tell you basically where is the white matter, which is down on the inside, and where's the gray matter, and where's the dividing line between them. So all of this is automated. It's all this automatic process that the computer does. And so by doing this, you can then say, well, I can automatically calculate the thickness of what's called the cortex, which is the gray outer shell of the brain. I can automatically get a sense of how thick that is. So why do we care about that? Well, we care about that because with dementia, that will shrink over time. And so that gives us a really, really specific, really precise measurement of the thickness of the cortex of the brain. And we can just get a really good sense of that and do it, like I said, in an automated way, in an automatic fashion. So this is just an example of some research studies that some of our labs have done to kind of look at this thickness measure and this shrinkage measure across different populations. So what you're seeing here in blue on the two panels on the left, and what you're seeing here in red and yellow on the panel on the right, is just areas of shrinkage in a group of people with this disease. So for example, you might take like 150 people with frontotemporal dementia, with Alzheimer's disease, or what we call young onset Alzheimer's disease, which means people that present with Alzheimer's disease before the age of 65. And you're just comparing all of those people, the thickness of the brain of all of those people, to the thickness of the brain of people that we know don't have any dementia and have no what we call neurodegeneration. And you get a map across the brain of what areas are most affected in the people that have the disease. So for example, in frontotemporal dementia, we see that these are the areas that are most effective. As the name implies, it's the frontal lobe of the brain. This is the front part of the brain. And the temporal lobes of the brain are very affected. But the back of the brain is not that affected. In contrast, in people that have Alzheimer's disease, whether it's young onset or late onset, it tends to be the temporal lobe also, but sort of more the back of the temporal lobe and the parietal lobe, which is kind of near the back of the brain, as opposed to the front of the brain that's affected. And so in this way, we get what some people might call a signature of the shrinkage. What is the sort of common regions of the brain which tend to shrink in people that have these diseases? Okay. So this can allow us within an individual or within a group of people to basically look at the shrinkage over time. And so this is an individual with a type of frontotemporal dementia. The type of frontotemporal dementia that we're seeing here is called semantic dementia. And what happens is that this is the temporal lobe. And in this condition, the very tip of the temporal lobe, which is kind of near your temple, as the name implies, kind of in front of your ear, the very, very front tip of it is the most affected. and that gets affected early on, as shown here in yellow and red. And then over time, it tends to spread backwards and to involve more of the brain. And so here you can see just a sort of slice through, again, this is as though the person's looking out of the screen, and you can see a slice that's kind of through the middle of someone's head. And if you look here on the right side of the brain, this is actually the right side of this person's brain, it's pretty nice and full, but compare that on the exact same, in the exact same regions on the left side, and you see that there's a lot of shrinkage here and a lot of that dark space that's taken up the area of the temporal lobe in this individual with this condition. So one of the new studies that we've been working on over the past couple of years or so is to say, can we track this progression over shorter intervals, right? So we could look at this area of the brain, for example, and we can say, oh, maybe it's a couple of millimeters of shrinkage here in what's called the temporal horn. This is one of the cavities in the brain, and we see a lot of shrinkage here. And then, we could look at it 2 years later and say, oh, well, look, it looks like it's gotten some more shrinkage. And you can even sometimes see that with the naked eye. You can actually just look at the shrinkage of someone who had an MRI, let's say in 2022, and then someone who had an MRI in 2024, and you can say, wow, it looks like there's a lot more shrinkage. And the longer you go, the more obvious, the shrinkage is going to be. But we wanted to come up with a measure that was more sensitive and that could detect shrinkage over a shorter period of time. So what we did was we actually got many, many images at the same time. And what that does is, by getting many, many images of the brain and of the thickness of the brain, we can basically get a more accurate assessment of the thickness than we would if we just got one. And so we can repeat that again, and instead of being able to detect that amount of shrinkage over 2 years, maybe we can detect it over 6 months. So that's just one of the other research studies that we're doing. And then this allows us basically to say, well, let's say, for example, that somebody's getting a drug to treat Alzheimer's disease. Now we can see if the drug is working over a period of 6 months, as opposed to seeing if the drug is working, having to wait like a couple years to see if it's working. Okay. Another thing that we can do with functional MRI, which is a type of functional brain imaging, is to look at networks in the brain. And so what we do, without getting too much into the specifics of that, is we have a way of looking at blood flow to different parts of the brain. And we do that by looking at the hemoglobin and the deoxyhemoglobin content of certain parts of the brain. And in this way, we can look at what parts of the brain talk to each other, and we call those different parts that talk to each other a certain network. So here, the brain is divided up by color into the different networks that comprise the brain. And basically, everybody has more or less the same networks. My network might be a little bit different, in a little bit different area than yours is, but not in a very different area. More or less, people have networks in the same area. And then we can ask the question, well, if you take a certain disease, what networks are affected by that disease? So in this case, this is a study that we did with people who have frontotemporal dementia. And in each of these panels, we kind of outline one of the networks of the brain. And then in this pie chart, we're showing by network, which parts are affected by frontotemporal dementia. What networks in the brain does frontotemporal dementia like to attack? This network, which is called the default network or the default mode network seen here in kind of reddish, is particularly susceptible to being attacked by Alzheimer's disease. And that makes sense because that particular network is very much involved with memory and how we think about the future, how we remember the past, and so on and so forth. So that particular network tends to be affected by Alzheimer's disease. So that's what the functional MRI stuff can do for us research-wise. All right, now we're going to move on to PET scans, and PET stands for positron emission tomography. Positron emission tomography, and we're going to see in a second why it's called that. So it's really similar when you go in and get a PET scan to an MRI. It's really quite similar. You get changed into the gown. You go in on, you lay down on a table. The table is slid into the center of this kind of donut hole. Your head is inside of it, but your legs are not. Your legs are always outside of it. There's a couple of differences. One is that it's not as loud. It doesn't make as many loud noises. Another one is that it's more of an open space. So it's not quite as tight as the MRI machine is. So it's not quite as, claustrophobic. But probably the major difference between a PET scan and an MRI from, somebody's perspective of actually getting these scans is that you are given an injection. So what they do is they put an IV into your arm, just like if you've ever gone to a hospital, or an emergency room and you've gotten an IV put in. Similar to getting, blood drawn, but they put this little tiny flexible tube in your arm, and then they give you an injection through that tube into your blood of what's called a radiotracer. And we'll talk in a second about what a radiotracer is. But they give you this injection, takes like, a few seconds, and then they remove the tube, and then they usually will put you into the machine. So that happens before you actually go into the machine. Another big difference between PET scans and MRI scans, remember I said that the MRI scan doesn't involve any radiation. It involves the use of a magnet, a very powerful magnet. The PET scanner does. So it actually uses a CAT scan machine, which is basically like a fancy X-ray machine. So it uses X-rays to take pictures. So you are exposed to some radiation by doing this study. You're also exposed to some radiation because this radio tracer is actually radioactive. So let's talk about what the radio tracer is and, why we use it and so on and so forth. So the radio tracer is basically a drug, which can be many, many different things, but it's usually a drug that binds to something, that is attached to something or can kind of show the activity of the brain. So if you made a drug like this, like let's say you kind of injected, something like sugar or glucose, and the brain loves to ingest glucose. It loves to use that as an energy source. And you just sort of injected sugar into someone's blood, and then you took pictures, you wouldn't see anything at all, right? Because you're not going to, there's nothing fancy or nothing that's going to light up from the just regular old sugar. So what you have to do is you have to make that radio tracer, that drug, radioactive. And that's why it's called a radio tracer. So these things are actually made in these fancy, very big machines called cyclotrons to make them basically radioactive. And so what happens, what are sort of the physics of what happens? Well, you get the injection of the radio tracer, which is radioactive. That goes throughout your body. And then that might bind to something in your brain, or it might, if it's a radioactive form of sugar, which is one of the most common radio tracers, it's going to be metabolized by the cells of your brain. And what happens is that it is going to collide with an electron. And the reason it collides is that it's going to emit these positrons. So the radio tracer, because it's radioactive, it emits something called a positron, and that goes and collides with this thing called an electron. And when that collision occurs, they basically blow each other up. So you get this kind of annihilation event, as it's called. And when that happens, it releases photons. And these photons then travel in opposite directions to these detectors. So what does that mean? How does that allow us to see issues? Well, it allows us to basically see the amount of this radio tracer that's in certain parts of the brain, because the computer basically detects where in the brain this collision occurs. And it also detects how many of the collisions occur. So this gives us a really kind of fuzzy map of where the radio tracer is being collected in the brain. Okay. So let's talk about Alzheimer's disease specifically when we talk about PET scans, because as some of you may know, In Alzheimer's disease, you have these two very classic changes that are seen in people's brains. And this has been known for, decades and decades and decades. Going back a long, long time, we've known that people have these changes in their brain. One of the changes is this plaque, which is called an amyloid beta plaque. And that is something that's outside of the nerve cells and just sort of forms as this kind of clump. Okay, and that's an amyloid plaque. You may have heard of the term amyloid when talking about Alzheimer's disease. The other one is a tangle, which is basically tau protein, and this is seen inside of the cells where you get this tangling of this other protein called tau. So these two big proteins that we think of with Alzheimer's, one is called tau, and the other one is called amyloid. One is put into a plaque, the other one is put into a tangle. So now we can talk about how can we use PET tracers to examine some changes that you might see in people with Alzheimer's disease without actually, taking a little piece of their brain and putting it under a microscope, which we never want to do, of course, right? So we just want to look at their brain without, doing anything invasive, without, just looking at their brain while they're laying there in the PET scanner. So one of the most common things that's used, as I mentioned, is something called fluorodeoxyglucose. So what that is, as I've said before, is it's just glucose. It's a molecule of sugar that's in, donuts and sugar and anything that's sweet, and that's broken down by pretty much almost a lot of the things you eat, and basically make it radioactive by putting this radioactive isotope right here, by knocking this thing off and putting this here, and that makes it radioactive. Okay, so now you have radioactive glucose, radioactive sugar. And like I said, the radioactive sugar, if it's in the bloodstream, your brain loves to take up sugar. It loves to use glucose as its source of energy. And so what you're going to get is a map of what's called metabolism. What areas of the brain are showing metabolism? What areas of the brain are using the glucose? And so you get just this map. And if you have a normal, healthy brain, you're going to see the whole brain light up, right? Because the entire brain, in a very uniform fashion, is using the glucose to make its energy, and whole brain's going to light up. If, however, you have a dementia, then like I showed you in some of the previous slides, there's going to be parts of the brain that aren't using the glucose as well as they should because they're just not as active. And you're going to see dark areas on the brain. You're going to see parts of the brain that look dark and that aren't lighting up. And that can give you a sense of the parts of the brain, like I said, that are degenerating or that are not working well in someone with dementia. A different type of tracer that you can do is what's called an amyloid tracer. So this is just the chemical showing what an amyloid tracer is. And this is, again, radioactive because you're attaching this thing to it to make it radioactive. But in this case, it's not glucose. It's actually a drug that goes into the brain and binds to that bad form of amyloid. So wherever it sees that bad form of amyloid, we have amyloid everywhere. Most of it's not bad at all. But this kind of bad amyloid that forms in plaques, it's going to bind into it, and then it's going to send off a signal, and it's going to give us a map of how much amyloid is in someone's brain, how much of this bad amyloid is in someone's brain. And so if you don't have Alzheimer's disease, or if you're very young and you don't have Alzheimer's disease, you're really going to see almost none of this. You're going to see a scan that's almost completely negative or just has tiny, tiny bits of this. But if you have Alzheimer's disease, you might see a really big concentration of amyloid everywhere. So there's a third tracer that's become very important, and that's called a tau tracer. So that's the other protein. Again, it's radioactive, and you give it and you can get a concentration of tau. So tau is interesting. I'm going to tell you why on the next slide, actually in a couple of slides. But first, we'll talk about the amyloid PET scans, because the amyloid is going to show us, the amount of amyloid that's in someone's brains. So interestingly, if you get above a certain age, about 30% of people who are cognitively normal, and that means that if you tested them, you did really difficult memory tests with them, you did really difficult, tests of their executive function and their thinking, and they're perfectly normal, about 30%, up to 30% of these people can have a positive amyloid scan above a certain age. But the thing is that this will increase with age. So it might be that, when you're 60 years old, the chances of having a positive scan might be like 10%, but when you get to about 80 years old, the chances of having a positive scan being cognitively normal go up to 30%. It also increases with certain genetic risk factors, which we can, talk about later, but we won't, go into now. So you can have a positive scan and still be completely cognitively normal and not, currently have Alzheimer's disease, but it does suggest that someone might be on the continuum. They might be on the way to eventually getting Alzheimer's disease. We don't know when that's the case. So let's say, again, somebody's completely normal. They score normal on all tests. They're doing very well functionally in their life, but they get an amyloid PET scan for a research study and it's positive. That suggests that they might be, on the way to getting it eventually, but we just, don't know when. In contrast, if someone is really struggling, if they're constantly forgetting things, if, their family's really worried about their memory, and if they get tested and they, do poorly on memory tests and then have a positive scan, that's highly suggestive that they actually have Alzheimer's disease, okay? A negative test, however, let's say you have a negative amyloid test, amyloid PET scan, that strongly suggests that you don't have Alzheimer's disease, okay? So that might mean that you don't have a dementia at all, or it could mean that you have a different type of dementia, because remember we mentioned these other types of dementia like frontotemporal dementia and Lewy body dementia. The frontotemporal dementia, in a pure frontotemporal dementia, you're not going to have any amyloid. You're going to have a different type of protein, and we haven't figured out how to detect that protein yet. Those proteins, I should say, yet. We just know how to do it in Alzheimer's disease. Okay, so this is just an example of the same person that is having all of these different scans, and this person happens to have Alzheimer's disease. And what this shows, what this really illustrates, is that the sugar PET scan, as I like to call it, the FDG PET scan, and the tau PET scan, and the MRI will all show where the degeneration is occurring. The amyloid PET scan shown here on the right is just going to kind of give us a yes or no answer, right? So an amyloid PET scan can be positive or it can be negative, or sometimes we get this kind of frustrating result where it's kind of borderline, like it's, a little bit positive, but it's not very clearly positive. But that's really it. And we don't think too much about where we see the amyloid in someone's brain. We're just trying to see if it's above a certain amount. For the other three guys, for the structural MRI, for the sugar PET scan, for the tau PET scan, we're really interested in where the issue is. So the structural MRI, like I said, we're interested in where these red arrows, where is the shrinkage? For the sugar PET scan, we're looking to see where are the parts of the brain that aren't metabolizing, that aren't using the sugar. In this case, it's the back of the brain. All of this red stuff, completely fine. You can ignore the center here. I know it's green, but it's supposed to be green because these are really the cells that would use the glucose, and all of these are using it really well, but these parts are not using it, this green area. For the tau PET, it's kind of similar to these two because the tau signal is really detecting what areas of the brain are degenerating. So you're seeing the same pattern. All of this redness in this scan is showing parts that are taking up the tau. So here you're seeing tau in the back, you're seeing a lack of sugar use in the back, and you're seeing shrinkage in the back. And this is all pointing to the back of the brain being a problem and the back of the brain showing neurodegeneration. This is just a different way of showing the same thing. So this on top, we would see, the results of shrinkage in a structural MRI. This would be people who are older but don't have dementia. This would be people who have Alzheimer's disease. So if you look at their PET scan, the whole brain in the healthy people, the whole brain's lighting up. Everything is using the sugar. Every part's using the sugar. Here you see green stuff because you're seeing that these parts of the brain aren't using the sugar as well. In the tau PET, no binding at all. This is completely negative in the healthy people. But in the people with Alzheimer's disease, you're getting binding, and you're getting a lot of binding down here, some binding here. So all of this is where the tau is, where the drug that we're giving is attaching to the tau protein and lighting up. And then in the amyloid scan, you're just kind of seeing it everywhere. Again, with the amyloid scan, it's a yes/no thing, more or less. It's kind of like, are you amyloid? Is it a positive amyloid scan or is it a negative amyloid scan? By the way, we have other ways of detecting amyloid in the brain without doing a PET scan. You can also do this with a spinal tap and looking at the spinal fluid. And most recently, we just started using blood tests to detect amyloid in the brain. So the spinal taps, I think, are going to kind of go out of style because we have these two other ways of finding amyloid. Luckily, the amyloid PET scans are now covered by Medicare. And so that's a really great advance. So we can just send people to get those if we're worried about that. And the blood tests are the next wave, the next generation, where we might just get blood tests on people to detect their level of amyloid and actually even tau in their blood. So what are some of the research applications of PET scans that we can do? Well, we can use amyloid PET scans, and this is commonly done, to determine whether someone should be included in an Alzheimer's disease study. So you may know that there is a couple of new medications that are these antibodies that are directed against amyloid in the brain. So there are these little antibodies that are injected. They go into someone's brain and latch on to the amyloid and then pull it out and then excrete it out of the body. So those studies, that's one drug study. There's been drug studies in Alzheimer's disease for 20, 30 years, and they've looked at different drugs that prevent the deposition of the bad form of amyloid, so on and so forth. But to get into these studies, to actually be eligible for these studies, we really want to know that someone has Alzheimer's disease. And it's not just that they're worried about their memory, but they don't have it, or maybe that they have dementia, but they have frontotemporal dementia. So the amyloid PET scan is an invaluable way of allowing us to know who should be included in these studies and who shouldn't be. Now, since the tau PET scans correlate to where the degeneration is happening in the brain, to where it's happening, these can be used to uncover where diseases like Alzheimer's start and to track the progression of the disease across time. So we can really see across time, it starts here in the brain and it's going to spread, maybe across or within a network to this area and then to that area and then to that area. So it really helps us to understand the biology of these diseases. And then amyloid and tau PET can be correlated to other measures, such as, the blood tests that I talked about. It can be correlated to cognitive testing. So it can be correlated to, how someone does on memory tests. It can be correlated to a whole bunch of other things. And then finally, scientists are developing new radioactive tracers that can measure things like inflammation in dementia. So you can sort of get a sense of how, what is happening from an inflammatory cascade point of view. Are there cells in the brain that are only activated when there's some kind of inflammation to kind of clear debris? And we need to look at, where inflammation is happening in the brain. Or I also mentioned that, a lot of the stuff we've talked about with PET scans applies really just to Alzheimer's disease. And we have very little way of testing what's going on in frontotemporal dementia in terms of these proteins. Now, we still can use the sugar PET scan. We still can use that one, the FDG PET scan, and we always do. We often do when we have patients with frontotemporal dementia. And as you may guess, when you do that, you see that the front part of the brain is dark and doesn't light up as much as the back part. But we still are lacking an ability to actually see the bad proteins that are in frontotemporal dementia. So this is an area of active research. So in order to do any of this exciting research, and like I said, to understand these diseases, we can't do it without you guys. We can't do it without subjects. And it's absolutely impossible. And believe it or not, there is, a couple of studies that I'm even doing now. And the problem is not, getting funding from the government. We've got the funding. The problem is not, necessarily the technology that we have. We've got the technology. We have the ideas. But the problem is just getting people The problem is just getting people to volunteer to do these studies, because without that, we just can't do anything. And we are obviously very interested in representing different ethnicities, people from different walks of life, to really just say, we want to know how these diseases express themselves in these people. We want to know how it is across, the age spectrum, because there are some people that are very young that get Alzheimer's disease. There are some people that, get it at the traditional older age. But really, we rely so heavily on your kindness and your generosity to take part in these studies. And like I said, there is radiation exposure with the PET scans, but luckily we give it at a dose that we think it is safe for people, and the MRIs are very safe. So we can learn a lot about these diseases by people's participation with very little risk. And so we would love for all of you, as many of you as possible that may be interested, to participate if you are willing. It's completely voluntary and up to you, but it would really, really help us to learn more about these diseases and eventually, conquer them. All right, so I'm going to stop my talk.
Wow. Wow, Mark, you crushed it.
Thanks, Mike.
You crushed it, man. I've got pages of questions, and you know what? I'm gonna go off script. Haley, I'm coming to you, but I want to go off script because I'm gonna start with the last question, and then we're gonna work our way through. Okay?
Sure.
Do you participate in any studies, and would you recommend your family to participate? So someone I love this question. Do you or anyone in your family participate in research studies?
Me, myself?
Yep.
I have had some family members participate. I haven't. Actually, I think I have participated in a couple. Yeah, so I have participated in a couple myself, and it's been a great experience. And it feels good to feel like you're making a contribution. And I have had family members also participate. I think, and a lot of our patients are actually, wonderful, and they'll say, like, if I can participate, and it's not too much of a problem, I'm not, living in Nebraska and have to travel to Boston or something like that, then I'm happy to, because, it contributes to our knowledge of these diseases and helps us understand them more. Yeah.
All right. So Mark, before I get to all my notes, because I'm telling you, I was jotting down all kinds of questions. And Christine, I'm going to get to you because I'm not going to read. I'm going to get to you, but first I want to. Well, you know what? Before I come to you, Christine, could you share what you wrote in the chat? Don't get shy now.
Are you saying Christine Ritchie or Christine?
Oh, Christine Ritchie. I'm sorry, Christine Ritchie.
Because there's Christine Cromarty has been putting some good stuff in the chat too, so I just wanted to make sure.
Yeah.
No. So I appreciate the question about, do you participate in studies? I'm a big fan of participating in studies, and so I participated in quite a few, and I did participate in one MRI study that I felt like I was in there for like 2 or 3 hours. I got such a great nap because I was so tired. So anyway, but I'm a big fan of recommending it to all my family members. And my mother, she's no longer with us, but when she was alive, she loved to participate in studies. And found she met new people. She was very outgoing, and so she really liked to participate in research studies.
Right. All right. So before I jump in with the questions that I wrote down, and I truly want, if folks have questions for Mark, you can throw them in the chat for me to butcher them, or you can raise your hand and Siobhan will unmute you and we'll call on you to, ask Mark your questions. But before we get there, Haley Chavez is one of my amazing co-workers also. Haley, if people want to know how to reach us, how to sign up for our registry, could you share that information?
Yes, I can, and thanks to everyone for your interest in research. It wouldn't be possible without you, the participants, like the doctor was saying. So I will put our phone number in the chat because we do have a research registry where we try to connect people with studies that they're interested in. So if you're interested in learning more about dementia research and learning about the studies that we have, I can put that phone number, and I can also put a link to one of our surveys, and someone from our team can reach out to you in the next couple of days. So I'll do that right now.
Thank you very much, Haley. All right, so Mark, let's get this party started.
Sounds good.
One of the first questions I jotted down is it's about shrinkage. We've got quite a few questions about shrinkage. So one of the this wasn't a question that was asked; it was actually sent to me on my phone. Is shrinkage where the memories are stored, and by shrinkage, do you lose? Is that how people lose their memories?
Yeah, so shrinkage, it's interesting actually, because in some of these, each of these diseases, you're going to get shrinkage in different parts. And even in Alzheimer's disease, this is something that not too many people know, and this is something that our particular clinic specializes in at Mass General. We see these atypical forms of Alzheimer's disease. So instead of somebody, coming in, for example, and saying, I'm having these memory issues and I keep forgetting where I put things and I'm repeating myself, they express problems with their vision. And they go and see eye doctors. And the eye doctor says, I don't see anything wrong with your eyes. And that's because Alzheimer's disease, the actual changes that I showed you with the amyloid and the tau, is attacking the visual parts of the brain. So you're going to basically the sort of way that someone presents is going to be mirrored by where the shrinkage is. So if the shrinkage is affecting the memory circuits of the brain, such as the hippocampus, which is very, very commonly affected in Alzheimer's disease, as well as what's called the parietal lobes and the temporoparietal lobes, if it affects those areas, which is where it typically goes, then you're going to have memory problems because it's affecting the parts of the brain that control memory.
Okay, all right. And by the way, again, folks, I'm going to say, and I apologize because someone had their hand up, but then they took it down, so we may have answered. But if you've got a question, again, you can throw it in the chat. We will get to it, or you can raise your hand, and I promise I'll call on you. So, Mark, this was an interesting question. I mean, they're all interesting, but I found this. Are there preventions folks can take to delay or prevent this?
Yeah, there have been many things that have been looked at for that. And probably the one that that has been the most successful, if we had to say, is physical exercise. So what we call aerobic exercise, actually doing some kind of exercise where your heart rate gets up. And so that could be something, as simple as walking. So I tell some of my patients, even go to the mall and just walk around. You don't have to, get on a treadmill if you can't because your knees, are shot or something, or you have a lot of arthritis. But that's probably number one. People also talk about like healthy diets, like a Mediterranean style diet that's relatively low in carbohydrates and that doesn't have like saturated fats and things like that. And then we always are asked the question about cognitive tests. So, we're always asked this, like, if I do Wordle every day, or if I do a crossword puzzle every day, will that, help me prevent it? And believe it or not, out of those three, that's probably the least, has been shown to be sort of the least powerful. But the other thing that I emphasize to my patients, and this is something that other doctors in my field might disagree with, is I think that all of these things are great to do, but I also like to emphasize to people that it's not this super, super powerful effect, okay? So the example I often use is like smoking and lung cancer, right? Like if you smoke, that drastically increases your risk of getting lung cancer and heart disease. But, the association between these sort of preventative measures and going on to develop dementia is not quite as strong. And the reason I say that is, number one, it's true. But number two, to sort of offset some of the guilt that some people have, because if somebody has dementia, you want to tell them this is not really, probably has nothing to do with the way you've lived your life. It's horrible, it's tragic, but it's not because of something that you did. So these are, some things which can offset your risk and delay your risk for sure. But there is still a strong, genetic component, and there are, many other components that we don't even understand yet for why these things happen.
So as somebody who hates doing crossword puzzles, I thank you.
Okay, no problem.
All right, so I've got a hand up. I apologize because I'm going to butcher your first name. So Kadrian Turner, if you could, Siobhan, if we could unmute that person and jump in.
Yes, good evening. I was wondering, as far as participating in the study, is there medicine involved at all, or is it just the X-ray?
Yeah, so that's a great question. I should have actually covered this. It's a really good question. There's usually two types of research studies that are out there for people to participate in, two big categories. What I've been talking about for the most part are what some people might call natural history studies, where we're just trying to understand the disease better. We're not actually looking to try to treat the disease. And in those studies, usually they don't involve any types of pills. The only kind of medication is that, you know, you do get this injection for the PET scans, which is usually flushed out of your body within a day, within a few hours. But there are other types of studies which are oftentimes called clinical trials, where the researcher is trying to is giving some kind of intervention to a group of people that have Alzheimer's disease, or maybe before they do, to see if you can actually treat it or prevent it. So they might, you know, have people exercise every day, you know, for a year, and then have another group of people that, you know, watch TV and sit around every day for a year, and then compare them and see what the rates of development of Alzheimer's, or they might give them a drug, or they might do a form of brain stimulation or something like that. So most of the studies, to answer your question, that I've been talking about are these studies where we don't give people any kind of pills or anything. We just look at their brains, just to get a better sense of what is normal brain aging, because that's really important, and what is, you know, what happens to the brain when it develops one of these dementias.
So, so Mark, since you brought up were you? I'm sorry. Okay, I believe she was done. Since you brought up dyes, and that between that and shrinkage, they seem to be the big hits. Can you explain a little bit more about the dye that goes in the tube?
Yeah. So with PET scans, it's actually not a dye, believe it or not. With this is something that a lot of people think, and it's, you know, if you've had like a CAT scan with a dye, that's actually what a dye is it is something that lights up your blood, or it lights up, you know, something else in your body so that doctors can see it. This is actually giving someone a drug that's radioactive, that is going to either that's either a radioactive form of glucose, which is, you know, which we consume, every single one of us consumes every single day. It could be a radioactive form of water. That's been used in some PET studies, not so much anymore, but that used to be used. Or it could be this drug that will bind to amyloid, or it will bind to tau. Or there's even, you know, some drugs that bind to certain neurotransmitters. So some people might have heard of dopamine, or you might have heard of serotonin, or you might have heard of norepinephrine, and it can bind to the receptors of these drugs. So it's not a dye in a sense. It's something that is basically a molecule that is radioactive, that is basically injected. And these molecules, because they're radioactive, they decay really quickly. Like I said, the most they ever stay in someone's body is a day. There's some of these molecules that decay so quickly that the PET scans fail, because you have the place making it, and by the time we're actually able to inject it, it's decayed. So it has, like, it only stays around for 15, 20 minutes. So they decay really quickly and kind of get excreted out of your body, but they do expose your body to radiation because they are radioactive.
So the next question kind of follows up. Do you need the dye to perform a PET scan? Because you mentioned, when we were talking about the CAT scan, you didn't need the MRI. You don't need the dye, but with the PET. So if you could give me a little bit more.
Yep. So for the PET scan, you do. So by definition, there has to be some kind, with a PET scan, there has to be some kind of radioactive drug, radio tracer that's injected. Otherwise, if you put someone in the PET scanner, you're just not going to see anything. It's just, you might, you know, it's a CAT scan machine, so you'll see a CAT scan of someone's brain. And if you're going to do that, you might as well just get an MRI, because it's a much better picture. So the MRIs, there's no injection whatsoever. But with any PET scan, you're going to have some kind of injection.
And so Ms. Turner asked a question in the chat, which is a follow-up. Is medication required to take the test?
Nope, you don't have to take any medication to take any of these tests. You get the injection, like I said, in a PET scan. And by the way, we do have some folks that say, I'd love to participate, but I'm not too thrilled about the idea of the PET scan. And those people can absolutely just do our MRI scans. But the only sort of medication that you take is when you're actually getting a PET scan and you get that injection through the PET scan.
See, now I know this is a question that I've been asked a lot of times. If you get a positive scan, and as you said, that there's a possibility of it becoming dementia, is there anything you can do to slow down getting Alzheimer's?
Yeah. So, some of it is the same things I was just talking about, like the exercise, the good diet, the crosswords to some extent. But there are these new drugs that I mentioned, which are these antibodies. And the first one of those was approved a year and 8 months ago or something like that. And then there was just another one approved a couple months ago. And, this is really exciting because it's the first drug in Alzheimer's disease that actually is attacking the disease itself, right? It's not just giving like a sort of symptomatic improvement. And the studies didn't show this huge effect, but it did show a little effect. And the reason I bring up these different drugs are that there could come a time, we're not there yet, but there could come a time that you get a positive test, one of these things, and we suspect that you might be on that track, on that train track, and we can give you these drugs to slow it down, or maybe even, if we're really fortunate, one day just stop it from ever starting. So that might be the future. I'm not saying it will be, but it could be that these drugs become so good that we screen people, for these things, when they're 40 or something like that. And then we give them, and then if we see that they have this tendency to develop it, that we give it really early. People are starting to look into that specific question right now. They're giving these drugs to people that are really early, or that maybe have a positive scan, but they're young and, and not symptomatic at all.
Which is, you literally just pulled the next question up. And it kind of sort of popped up, but it piggybacks on what you just said. Can dementia be detected at a young age? Now, you mentioned young onset. So I mean, you owe it to our folks. Explain what young onset means.
Yeah. So it usually, we're not at the point at all where it can be detected. Like, let's say somebody's going to develop Alzheimer's when they're 78. Can you, if you found them when they were 30 or 38, we're not at the point where we would know anything about that early in their life. So usually even these types of scans and the spinal fluid can detect amyloid at most maybe 15, 20 years before they actually have symptoms of the disease. And that's more the spinal fluid than it is the PET scan. But to answer your other question, Mike, about the early onset disease. So when I say early onset Alzheimer's, what I mean is that somebody actually has full-blown Alzheimer's. It's not just that they have a positive scan or that they, have one of these things in their blood, but they have, significant memory loss, and you do a workup, including maybe the amyloid PET scan, and you're diagnosed with actual Alzheimer's disease. And all of this happens before the age of 65. And so we've seen a lot of people like that. And unfortunately, it's rare. You think, like, if somebody is 50 and they're forgetting things often, there's the whole movie about that, Still Alice, with Julianne Moore. I think she was supposed to be, her character was 51 or something, if any of you've seen it. So there are people that, when they're 50 and you would think, oh, they can't have Alzheimer's disease, they're 48 or they're 50, and yet it rarely can happen. And so that is what we would call early onset Alzheimer's disease.
Now, there's another theme of questions that have popped up, and we've heard now for years about concussions in football players and boxers. Someone asked the question, can brain surgery be a cause of dementia? Someone else asked the question of, can brain, physical assault in your younger years. In other words, these things damaged the brain.
Yeah.
Can this go on to cause Alzheimer's?
Yeah. So couple of different answers. There is an association in general. So there are certain like risk factors for Alzheimer's that were identified long ago. And one of them is a history of head trauma. That does not mean that if you've had a concussion or you played football, that you're destined to get Alzheimer's, or, so that's one thing. Let's talk about the brain surgery next. Let's say you had brain surgery and then you wake up from the brain surgery and you're having significant memory problems, or you can't speak, or, something like that. That wouldn't be considered dementia. It would still be considered, an impairment, and you have a cognitive deficit, but we don't call that dementia because it happened immediately, right? So dementia by definition is this slow, progressive, usually relatively slow, at least over months, and usually over years, of progressive more and more and more cognitive decline over time. In the case of a brain surgery or an assault, let's say somebody's assaulted, they wake up the next day and forever, they have brain damage, tragically, that wouldn't be dementia, because that's, brain damage that's causing the issue. It's not this, the same biology that's happening. Now for football, and this is always a tough situation because I'm a big football fan, so this is a tough conversation for me. I have to resolve this with what I do for a living. And boxing is a whole other thing. Boxing is a whole other level, because
that's a show for another night.
That's a show for another night. It's, I used to have a mentor that would say it's the only sport where the intention is to cause brain damage. You're actually trying to, hurt the other, cause a concussion, right? So
it wouldn't by any chance be Bob Stern, would it?
No, right. That's somebody who's very much against, but boxing is, hopefully that'll be outlawed, but the person who asked that question is absolutely right, that there is an association. It's so funny. My son and I both like football. He asked me this exact question the other day, just like you guys are asking. The question he asked me is, well, do all these linebackers and these people get these repeated, hits to their head, and do they all develop dementia? One thing is the dementia that they develop is called CTE, as you know, and so chronic traumatic encephalopathy, and it's a slightly different pathology, so it looks different under the microscope than people with Alzheimer's. And we know that a lot of the football players that have gotten their bell rung 100 times don't develop it, and we know that some of them do that haven't as much. So there's definitely an association. There's no two ways about it. There's definitely an association between repeated, blows, even if they're what's called subconcussive. So you get a knock to the head. It doesn't cause an actual concussion, but you still get a good, knock to the head, and the development of dementia. But there probably are, I think, some other factors that come into play, like maybe genetic factors or, something else that can make it so that the same amount of trauma in one person, they're definitely going to get CTE versus another person that may not get it.
Yeah. I'm by the way, everybody, I am loving these questions.
Great questions.
I mean, I've got the ones jotted down and I'm scrolling through. So if you've put something in the chat, I promise we'll get to it. But this is an interesting question. So the spinal fluid would be best for someone younger who wants to know.
Yeah, you could. So the younger, I don't know if they're asking this specifically for because the amyloid PET is only covered by Medicare. So we've had patients, I've had patients that have come in, and I really want to know, like, if they have underlying Alzheimer's disease. This happens all the time in my clinic, but let's say they're 54 and they don't have Medicare yet, and so they can't get an amyloid PET scan unless they want to pay like $9 grand or something. So they're not going to do that, obviously. So what we do is we usually send them for a spinal tap, and then we can get the amyloid. In the future, like I said, these blood tests are starting to show that they have the same ability to detect amyloid almost as the spinal tap and the amyloid PET scan. So it might be that even 5 years from now, we're going to be, doing blood tests to look at this in people.
So let me play devil's advocate. Let's say my insurance isn't going to cover a scan. If I sign up for a research study that includes a PET scan, do I get it for free?
You do. You're absolutely right. You do get it for free. A lot of the studies that we do include an amyloid PET scan. We are struggling a little bit with sort of the ethics of telling people though, right? Some studies will tell you, look, you got an amyloid PET scan and it's positive, right? But let's say, you're a good, kind-hearted person and you want to contribute to research and you're doing fine, everything's great in your life, you don't have any memory problems or anything at all, and you do this amyloid PET scan and then we tell you, oh, it's positive. So all of a sudden your life has changed, right? You now are saying, oh my God, like, am I going to develop dementia in 10 years? And so there's some, issue surrounding it. If it's already clear to somebody that they have a memory problem and their whole family knows about it and it's advanced, and then they get a positive, then, that's not that might not be as jarring psychologically because they're already anticipating that there's an issue. But if you're just, doing research and then you get this positive test, even though it doesn't mean you have Alzheimer's disease, it still, can be disturbing to people. So we're actively working on how to relay results to people because we want to be able to, give back to the people that do research with us and give them information that might be useful to their health. But at the same time, we want to be sensitive about not, really like upsetting them and that kind of thing.
Scaring. But you brought up a good point. So what if while I volunteer for a scan for dementia and you find something else, such as a brain tumor?
Yep.
What happens?
So great question. And we have that actually like in the consent form, whenever you sign a consent form to do a study, that's in almost every one of our imaging consent forms. So if we find something like that, and it's really rare that we do, it's actually, I've done a lot of studies and seen a lot of scans, and usually most of the time we find something that looks a little strange, but it's kind of a normal variant that somebody's had their whole life and it will never cause them problems. But let's say we do find a brain tumor. What we would do in that case is we would immediately tell someone. And what we would do is we would, if they want us to, we would call their doctor and tell their doctor that we saw it. And then we would also very much encourage them to get a clinical scan because, the scan, whatever we're going to do is not the best thing to look at a brain tumor, right? So we would tell them, you really should get another MRI to specifically look at this thing. So we want you to, we would tell their doctor that, but we would always tell people if we happen to see that by chance.
So I'm now gonna do what I hate doing. So what you're saying is if you find something that's, oh my God, you guys sit with my doctor and me and say, here's what we found. Here's a path.
Yes.
So to speak.
Yes. This is what, we say, we found this, and we would say, we think you should get this type of scan, and we think you should see maybe a neurosurgeon.
There you go.
And to look at this. And this is different than telling the amyloid result, right? Because that it's kind of like they may or may not develop it. This is like you have something
Got something
really affecting your health today, and you really need to get on it today. So we have to tell them about it.
All right, Miss Sheila, I see your hand up. Jump in here. Sheila Ross, I'm looking at you.
Good evening. I was just wondering, is it common for people that are receiving dialysis and people that are getting medication for cancer? Is it common for them to develop some kind of Alzheimer's?
So Sheila, they don't develop Alzheimer's, but they can develop problems with their thinking. So if you get dialysis and, or if you haven't gotten dialysis and you need dialysis and all of these kind of, toxins are in your body, or you have, all of these things that haven't been cleared, or, if you're getting chemotherapy, there's this term that you may have heard of called chemo brain that some people talk about, like that some people getting chemo, like, and it's oftentimes it's not necessarily memory stuff. It's, I can't concentrate. I have trouble planning things. I have trouble organizing things. I have trouble scheduling. I have trouble keeping track of things. I have trouble doing more than one thing at once. So these are very common things, and they're very real, and they're caused by the things you're talking about, but they're not Alzheimer's. So if you looked at someone's brain under a microscope, even if they're getting chemo, or even if they're getting dialysis and all this stuff, you wouldn't see any of the things I was talking about. You don't see any amyloid, you don't see any tau. If you do the amyloid PET scan, you don't see any of that. So they have problems, but the good news is that in those cases, sometimes those are reversible. So if somebody needs dialysis and they get it, it gets better. Or if someone stops the chemo, it could get better. So it's not Alzheimer's. It's having problems with your thinking, but it's not Alzheimer's.
There you go.
Thank you.
You're welcome.
Welcome. All right, Ramona, I see you. Come on. You can take it. Can Siobhan, can we take Ramona off mute? We'll get to you. Well, I heard somebody. So Ramona, can you try and take yourself off mute?
I'm hitting her button.
There you go.
There you go.
There you go. Go
Oh.
ahead.
Okay, so for me, I just want to ask. So, in 1984, I had ovarian cancer. So I went through the chemo and radiation. 2 years later, I ended up having a stroke. And I just want to know that because I had the chemo and radiation, and then I had the stroke, am I prone to get Alzheimer's or dementia early in my age?
Not necessarily at all. There's people that get strokes and that never get Alzheimer's. So there is a type of dementia. Again, this isn't necessarily Alzheimer's, but that you might have heard this term vascular dementia, where people get a lot of strokes and then they can have problems with their thinking because of that. So if it's just one stroke and if you've recovered from it, there's no reason to think that you're necessarily that much more prone to get Alzheimer's than anyone else. The only exception to that is that sometimes people with strokes also have high blood pressure or also have diabetes, and those are associated with both strokes and Alzheimer's disease. But in and of itself, the fact that you had a stroke doesn't necessarily mean that that you are going to have those issues, that you're going to develop that disease.
All right, Lily, I see you. I'm going to come to you in a second, but hey, Jackie. Jackie's got a question, which I've heard this question before. The question is this: you forget where you put your keys. You forget the names of folks you've known and for a while. And in my family, and it sounds like the same with Jackie. We've had folks in my family with Alzheimer's, well, with dementia and some with Alzheimer's. And now, especially those of us who are older, it's like, oh crap, where did I put my keys? Oh my God, I got grandma's thing. So the question is, she's asking the question, should she talk to her doctor about her concern? My answer is always yes. What do you say?
Yeah, I would say yes, for sure, if you have any concerns. But there are some things that happen, with aging that are benign, as you get older. So the classic thing, one of you, like you said, is where do I put my keys? Another classic thing is you go into a room and you say, what am I in this room for? And I do that, I've done that for 20 years. And so that, there are these things like that, that really in and of themselves, if there's nothing else, and, also as you get older, maybe into your 50s, 60s, 70s, 80s, forgetting someone's name or taking a little bit longer to come up with a word once in a while, those are all normal things, right? So if it's just those small things and you're still doing really well in your life, you're not forgetting important things. One of the red flags that I always point out for Alzheimer's is repeating things. So if you were to sort of ask the same question from people, even though you talked about a topic, you understood what they said, and then you're asking again, when are we going to the doctor? And your loved one says, I told you 5 times the appointment's at 1 o'clock. That's a red flag, right? Or if you forget something really important, like, your daughter moved to California and you can't remember that she did, that's a red flag, right? But the kinds of things that you're talking about, they might just be normal aging because they're so, they're so small and benign. But like you said, anytime you're concerned, you should, err on the side of bringing it up to your doctor.
I always tell folks, if I came down with dementia, I've never been good with remembering names.
Yeah.
So my kids have a built-in excuse
Right.
that if it's like, well, dad never was good with that.
Right.
So they're not going to notice though until the wheels start to come off.
No, but you're absolutely right. Actually, all kidding aside, like that's a good thing to think about. Is there a change? So if
Yeah.
somebody has always been bad with names, or they've always misplaced their keys, you know, and now they're doing it a little bit more, that's a little less concerning. It still could be concerning, but if there's this new thing that they would never have forgotten, that, you know, that's a little bit more concerning, a little bit more of a red flag.
There you go. All right, Miss Lily, I told you I was coming to you. Let's get you off mute. Jump in here.
Well, I was just wondering, I do kind of like have problems remembering things, forgetting, but I was wondering the program, the study,
Mhm.
what is the qualifications? Do you have to, suffer memory losses to take part or what?
What a great
Wait.
question, Lily.
Mark, I just want to say, I did not pay her to ask that question.
Right. Yeah. The answer is you don't, there's really no restriction. There's very little restriction. We have studies for people that are, you know, above a certain age that are completely fine with their memory. We have studies for people that are having mild problems with their thinking and their memory, and we have people that have significant problems. So we usually take all comers. There are certain things that you can't get an MRI. So let's say, you know, if you had an aneurysm repair in your brain, or you have a pacemaker, that's a big one. If you have a pacemaker, you just can't get an MRI for all intents and purposes. But other than those kind of basic things, we take a lot of people, you know, across the spectrum.
Yeah, I remember my doctor had the word you was using a word here tonight, and amyloid.
Oh,
Uh,
amyloid, yeah. Mm-hmm.
amyloid. I had taken a blood test for that
Oh,
amyloid.
interesting.
So, but from my understanding, it didn't have anything to do with Alzheimer's. I thought it was something to do with cancer.
Oh, well, it could be actually. This
Because it was
this trips
oncology.
people up. You're right. There is, you know, there are other amyloid diseases in the body
Okay.
that aren't directly related to Alzheimer's. Like there's something called amyloidosis that can
Okay.
affect like, the heart and the
No,
liver.
that's the word.
Yeah, amyloidosis. So it might
Yes.
be that. And even I got confused, you know, about that too. Like it's the exact same word. And so
Okay.
it's the same protein. Amyloid is a protein that's throughout our body, but this
Okay.
is like a certain type of it that's being deposited in the brain that's causing Alzheimer's.
Okay. That's why I was asking you the qualification, because I
Yeah.
kept hearing that
Yep,
word.
that
So I
might be what
wanted,
it was. Yeah.
There you go.
okay.
Thank you, Ms. Lily. All right.
Thank you.
Excuse me,
I've got.
does a brain aneurysm cause immediate death? Can you survive a brain aneurysm?
You can. Brain aneurysms can either be very, very mild, or they can be really, really bad. So you can have, you know, an aneurysm is basically like, you know, the blood vessels in our brain are like these little tubes, like hoses. And then sometimes they get like a swelling on them and then it bursts. So that's what an aneurysm rupture is. And so you can have a very small aneurysm that just leaks a little bit of blood and you just get a really bad headache, and you know, they fix the aneurysm and you're fine, or you can get, you know, very unfortunately, this massive bleed, and then you could, you know, have a really bad outcome.
Yeah. So, Philip, I've got your question in the chat. I'm going to paraphrase it because I don't want folks to get lost. What Philip has wrote was, I have Parkinson's disease stage 2, as well as mild cognitive impairment. So he was wondering what he can do to reduce his risk of getting dementia. And Mark, you kind of you answered this earlier when we first started. He wants to know, is Parkinson's dementia, Lewy body dementia? In other words, you mentioned the different types, and you know, you did the umbrella, and you know, we know Parkinson's is under the dementia umbrella. As my uncle was misdiagnosed with Alzheimer's, and he ended up having misdiagnosed with Alzheimer's, and he ended up having Parkinson's. So I guess what the question is what's the difference between, you know, Parkinson's, AD, Alzheimer's disease, Lewy body, and I'm gonna, Philip, if it's okay with you, I'm gonna tag on. When you go get tested, do they test for all or one in particular?
Yeah, this is a question, Philip, that a lot of doctors that aren't neurologists, and maybe even some neurologists don't know the answer to. So it's a great question. So if you have just regular Parkinson's, let's call it regular Parkinson's, the fancy term is idiopathic Parkinson's disease. There's more and more research implicating that those people can have problems with their cognition. That does not mean they have Lewy body disease, right? They just have regular Parkinson's disease. And oftentimes the issues that they have are issues with what we call executive function, such as paying attention, focusing, planning, organization, those kinds of things, as well as visuospatial function. So, processing shapes and distance and all those kinds of things. So not everybody with regular Parkinson's develops cognitive problems, but we are more and more aware of people with Parkinson's in general having cognitive problems. Now, let's say that somebody has significant cognitive problems with Parkinson's. There is this entity that sometimes has been known as Parkinson's disease dementia, sometimes called PDD. And those are people that actually develop, full-blown dementia with Parkinson's disease. So the question that's a really, advanced question is, how is that different from Lewy body? And, is it like what in the brain is different is than in Lewy body? Well, so Lewy body technically has this definition that you have to have the cognitive changes and the Parkinson's within about a year of each other. So one can come before the other, but usually they, sort of appear around the same time. Whereas, the Parkinson's with dementia, it could be that you have Parkinson's for years and you slowly, get this dementia. Now, the other great question is, what's going on in people's brains? So if you look at someone with pure Parkinson's, or with Lewy body disease, pure Lewy body disease, they have in their brains, it's not amyloid necessarily, but it's Lewy bodies. So with Parkinson's, with pure Parkinson's, the Lewy bodies tend to be in parts of the brain that control movement. But in Lewy body disease, they tend to go everywhere. They're really throughout the brain, and that's why you're getting all of these cognitive issues. And people with Lewy body disease differ from Parkinson's, number one, in terms of, the onset of the symptoms within a year, like I said, but they also can have visual hallucinations. They can see things that aren't there. They also can have these big fluctuations in their cognition. So they can have days when they're really sharp and other days when they're like in a trance, almost like they're just sort of staring off into space. And everybody has good days and bad days with dementia, but these can be really radical, like really good days and really bad days.
Sir. Are brain aneurysms painful?
They can be yeah, they usually are actually. When they first rupture, they're usually like the worst headache of someone's life. That's
it's like a headache. It's not like a localized pain.
No, it's a headache. It's usually described as like, almost like you're being hit with a bat or something. It's like a really sudden, really bad pain.
Okay, thank you.
Sure.
Roxanne, I would say if you're concerned that you may have a brain aneurysm, you should immediately go see your doctor.
Yes.
It's not one of those, let me take some Tylenol and see if
that's right.
better. You immediately want to go see your doctor.
That's true.
All righty. All right. So Miss Cynthia, I thank you for your patience. Hey there. Come on.
Hi, Mike. How are you?
I am good.
Listen, I can't complain. I won't complain. Not to take anything from this very important and informative conversation. However, on a lighter note, I heard Dr. Mark mention walking into a room and forgetting why you came there. So this is something my family and friends have tried for years, and it works 9 times out of 10. If you're in your living room and you want to, like you just walk into the kitchen and you forget, go right back to the room that you were in and then go back to that kitchen. And 9 times out of 10, you will remember. Does that sound familiar to anyone?
Stop talking about me like that. Stop talking about me like that.
Why is that, though?
I think the only thing I can come up with, Cynthia, is that memory relies heavily on associations.
Yep.
So, and there's something, what you're getting at is this, this term called episodic memory or even source memory. where a lot of times you remember things, you link a memory to how you achieve the information, how you acquired it. So if if you acquired the memory, while you were on vacation, in a different, in Florida or something, and you might link that information to it. So maybe by going into that first room to begin with, you're given a hint. And that's one of the things that's different about people with Alzheimer's disease. I used to use this anecdote, and it's kind of true, but it's not 100% true. I used to use this saying to teach medical students that it's kind of the difference. Like if you tell someone, like a husband or your spouse to get orange juice from the store, they come back and there's no orange juice, and you say, "Where's my orange juice? I asked you to get orange juice." So there's a big difference between somebody that says, "Oh yeah, shoot, orange juice, I forgot," versus somebody that says, "What are you talking about? What orange juice? You didn't tell me to get orange juice." So there's a big difference, and I've always felt that it's always a little reassuring when something reminds you of something, and a hint or a clue will allow you to bring that information back, versus if the information's totally gone. Now, people with Alzheimer's still might be helped by clues, but as the disease progresses, it tends to be that even clues and hints, and even giving them multiple choice, like you could say, "I told you this word, and I'm actually giving you 3 words, and one of the words is the word I told you," it's still, they can't come up with it at all.
It's not there.
Hints can help a lot.
Yes, thank you. And Mike, you said you experienced that and it works for you. And I said family and friends of mine. So let me find out we're related. Good night.
Leave me alone. Leave me alone. But Mark, there's a really great question, and I see you, Janelle. I'm going to come to you in a second. There's a great question in here, which I hear all the time when I'm giving talks in the community, of people of reasons people give for not wanting to participate in research. The question here is, are there any side effects? And I'm gonna tweak this by saying, are there any negative side effects to having any of these research studies done, but participating in research?
Yeah, so I would say, for the MRI, let's start with the MRI. Like I said, we screen people to make sure there's no metal in their body and they're not bringing any metal. We actually do the whole airport thing, the TSA thing, where we get the wand and wand you down to make sure you don't have any metal. So long as you don't have any metal on your body, like you're not bringing metal in and you don't have metal implanted in your body.
Right.
Yeah. So long as you don't have that, or you don't have a pacemaker or certain things, if you pass that screen, there really are, I would say there's no side effects at all. There's even, it's loud, but we protect your hearing, and there are people that have gotten, so long as you don't get like 100 MRIs, maybe that will affect your hearing because you're constantly getting this loud noise. If you're really claustrophobic, then you might not want to go into the MRI because, you might have a panic attack or something, because if you really hate like closed spaces. But other than that, really, there's really no side effects at all about getting an MRI. I really feel like you can get a lot of these and get them very, very safely. And they've been around since the 80s or so. So this technology has been around for a good 40 years, and it's incredibly, incredibly safe. Now, the PET scans are a little bit of a different issue. You won't get any side effects in the moment, right? So sometimes people ask me with PET scans, you're getting radiation. Does that mean that your hair is going to fall out or that you're going to start vomiting? And that does not happen at all. It's possible that you could get an allergic reaction to the radioactive drug. That's extremely unlikely. And even if you did, what would happen is you'd start getting hives or something. Again, very unlikely. And they would give you some medicine right there to prevent it from getting too bad. But the one thing with the PET scan is you are exposed to radiation, right? So there's nothing that's going to happen that day, but your body is still exposed to radiation. So we, tell people about that, and we want them to know it. And we still think it's safe. We think that, what we do is we compare it to the amount of radiation that you get just by being alive on the planet Earth, because all of us get radiation from the sun. There's actually radon, which, you hear about in houses, and look for radon in your house, but there's radon actually throughout the world. So each of us gets some degree of radiation. And usually when you do a PET scan, you get maybe like a few years worth of that background radiation, or it's kind of similar to getting, a couple of CAT scans. So it's that level. Now I tell people that's much more than if you get an x-ray at your dentist. That's almost nothing. You know, you go to the dentist, they x-ray your teeth or something. You fly in a plane, you get a little bit of radiation. That's really tiny amounts. It's much more than that, but we still think it's in the safe range for people. And we still think it's very unlikely that that would lead to, you know, developing cancer in 20 years or something like that. So hopefully that answers your question, but you still are exposed to a decent amount, but we still think it's safe.
There you go. All right, Miss Lydia, I apologize. I didn't see your hand up. Come on.
Hi, how are you?
I'm
Hello.
good, thank you.
So my question is, so my grandmother, I believe she's turning either 93 or 94 in March. Now, I find it interesting that when we go visit her, and I can bring people that she hasn't seen in years, and she remembers them.
Mm-hmm.
She remembers stories from years ago, but she can't remember the now. So is that like a normal type, or is there different ways of how people's dementia reacts for them? Because it's interesting. She'll tell us stories about when we was down south in Alabama on the farm, and then it's like you can say, "Oh, Graham, remember the conversation we had on the phone yesterday?" And it's like, "Huh? What? What are you talking about?"
Yeah. So it's a great question, Lydia. And unfortunately, I think this is something very common. And I also, unfortunately, I don't think it's normal. You know, as you get older, like I said, you do have more benign memory issues. But this is something that is very common in someone that's developing Alzheimer's disease, or, you know, maybe even has it, that recent memories are really difficult. And those long-term things are perfect. In fact, in my experience, you almost wonder if they're better, the long-term stuff, like they're actually sharper. And it's very common for people with Alzheimer's to talk a lot about things that happened a long time ago and to do it accurately, right? It's not like they're making stuff up about 30, 40 years ago. It's absolutely correct, but they're talking a lot about it. And so sometimes family members will be like, why are you kind of bringing that up? I mean, it's interesting, but why are you bringing it up? And so that brings up this interesting thought, like, does that actually get better? You know, the long-term stuff, at least in the short term, as the short-term stuff goes away, or is it just that they're having so much trouble accessing that short-term memory that they, you know, are defaulting to sort of the long-term memory stuff? But it's really common. Usually Alzheimer's people with Alzheimer's, unless it's very advanced, they don't forget about high school. They don't forget about like their wedding day. They don't forget about, you know, that kind of stuff. The thing that they have biggest problem with is what happened yesterday and what happened 2 days ago.
Right. And the thing is, if we tell her, we'll say, Graham, I think, you know, you're forgetting. She'll fuss at us.
Yeah. Oh, yeah.
She's a firecracker.
That's another huge thing is how much.
Yeah, she'll fuss. Like, memory is here. And like, okay, Graham.
That's the thing that one of my colleagues studies is like this idea of insight into whether you have memory problems. Because some people, it really bothers them and they know it. And they're like, I'm forgetting things, and they really get upset. And then other people like your grandma, they're like, there is nothing wrong with my memory. I'm 80 years old. You're going to have memory problems as you get older. And then their family says, yeah, but you forgot literally how to get to the local store. And they say, well, you know, everybody does that. My memory's fine. So you hear that a lot.
Lydia,
and just one more question really quick, that she had a stroke probably about a little over a decade ago. And I'm wondering, does that speed up the process of dementia for someone her age, or no? Because,
you know, if they already have it and there's a damage to, especially if it's a big stroke, that could, because then they have less part of the sort of areas of the brain to compensate for the process that's going on. But yeah, that would be the only way in which it kind of could speed it up. But if it's a small stroke and it affected just the sort of physical motor parts of the body, then not necessarily.
Okay, thank you.
Yeah, sure.
You know what, Mark? This has been so amazing. I forgot to ask if folks want to find out how to get in touch with you, man.
Yeah, we can give you our clinic number, and this would be a number to call if you or a loved one is interested in getting evaluated, and you're, you know, near Mass General, and you can either come see us, or you're in the state of Massachusetts and you can do like a virtual visit. So that number is 617-726-1728.
All right.
That's
We're
the
gonna-
number of the Memory Disorders Clinic at Mass General.
And I promise I'm going to ask him that question again before we wrap up. Also, I want to, if Haley could jump in, because Haley's got, look at that. Look at that. The phone number just popping up all in the chat.
That's what I was going to say. Can you put it in the chat? Or I
It's,
see it.
it's like magic. It's you know what? It's like magic, but real. Haley, can I ask you to jump in real quick and share with folks about the evaluation link?
Oh yeah, and sorry I had to go off camera. I had to switch to my phone. But yeah, I'll type in a survey link if you guys can share any feedback about this event. If you liked it, if you have any suggestions, please feel free to leave them in that survey. Thank you.
Excellent. Thank you much, Haley. You know, Mark, I was going to say to Lydia, with my grandmother, when she would get feisty, we just learned to live with the moment. If grandma says it's Tuesday, it's Tuesday.
I think that's the way to go, actually. I think that's the way to go. Yeah. Yeah.
It just made life easier.
Yeah. If you can. Yeah.
So let's jump in the Wayback Machine. So you mentioned the Mediterranean diet, and somebody asked, is that similar to the DASH diet? Which I've never, but before we get to the DASH diet, can you, on behalf of Nancy Emerson Lombardo, can you share about the Mediterranean diet?
Yeah, I'm looking up the DASH diet because I should know what it is, but I don't.
I just know about the seasoning.
Okay. Yeah, it looks like it's similar.
Mark, I can help with the DASH diet. If
Yes, please. That'd be great.
Oh, Christine, come on, jump in.
So the Mediterranean diet is the diet that you often think of when people are coming from the Mediterranean area. It's high in fruits and vegetables and fish and olive oil and things like that. And so it's kind of that diet that's sort of low in red meat or saturated fat, or but sort of what we call the good fats, which are fats coming from things like olives and avocado and safflower oil. The DASH diet is a very special form of almost what you would call the Mediterranean diet that's really focused on high amounts of fruits and vegetables, especially vegetables, and especially vegetables that are high in levels of potassium and a diet that's low in sodium. And it was really developed, the DASH diet was really developed to reduce people's blood pressure. And when they did a large clinical study of the DASH diet, what they found is indeed, it actually did lower people's blood pressures, not by huge amounts, but by enough that it would actually improve their overall risk for reducing their risk for like heart disease and stroke and that kind of thing.
See, there we go.
Christine.
So before we run out of time, Mark, because I realized we didn't have this conversation. So someone has reached out to your clinic. They've got the information. Let's walk through the steps. What's, first step, in other words, from the first time I reach out and say, I'm very much interested in participating in this, to I'm going into the donut. What are the steps?
Okay, great. Yeah, absolutely. Great question, Mike. So what the steps would be is, if you're interested, we have, a network of really hardworking people that would decide what the best study is for you, or what, studies really, it's usually more than one. They usually say like, you could probably be eligible for these few studies. And then we have, for each of the studies, they usually have a young person who's like, maybe out of college, that is a clinical research coordinator that is oftentimes the person that reaches out to individuals and just does like a screening of them to see if they would be eligible. And so we talked before, about like having a pacemaker. If you did have a pacemaker, they might ask you, do you have a pacemaker? Because if you do, you definitely can't get an MRI scan. They might just ask some demographic things like, how old are you? And, where do you live? Like, and just tell you a little bit about the study. So they might say like, oh, this study involves coming in just once to Charlestown, which is where I'm sitting actually right now in the Charlestown Navy Yard. And you know, it will last like about an hour, and that'll be it. And then they'll tell you like how much you're compensated for being in the study. You know, as a general rule of thumb, you never pay a penny for being in a study. You receive money for being in a study. So they have different levels of that. And so they'll give you all that information. And then, you know, they'll say, as I've done this myself, they'll say like, you know, you look like you'd be a great candidate. You know, you pass all of our criteria, which aren't very many. And then the big question is, do you want to participate? Because this is what the study would involve. It involves coming there. It involves this amount of time commitment. And then they'll ask you, what do you think? Do you want to participate? And they'll emphasize that it's completely voluntary. You know, you absolutely can say no, and that doesn't affect any clinical treatment you ever get at Mass General. But you know, this is what it involves, and what do you think? And then if you were to say, yeah, I'd love to do that. This sounds great. Then the next step would be they would say, okay, well, we have openings on, you know, Friday, September or whatever, September 27th at 11 a.m. Is that a good time for you? Or we also have an opening on October. And then you would say, yeah, that works. And then they would give you directions about how to get here. And then oftentimes, almost universally, if there's, yeah, I see it. Yep. If you can't come, the vast majority of our studies, not all of them, but the vast majority, as far as I know, will be able to, you know, compensate you for getting over here. So that might be, depending on the study, that they can actually call an Uber for you, or it might be that you get an Uber and then we pay you back for that Uber. Like you give us the receipt or you tell us how much it was, and then they compensate. It's, you know, differs from study to study, but most will. Some studies actually give you a little bit of lunch. And I bet Christine and everyone from the OrCor knows probably more about this stuff, could know more about this stuff than I do. So please chime in if I'm forgetting anything about these procedures. But then you'd come in and they actually could give you a lunch voucher. If you drive, they can give you parking voucher for, you know, so you can park for free. And then you come in, you get changed, put your clothes in the locker, you get in the hospital gown, and then you get in the tube, and then you're out, and then you go home. Whichever way that we set up transportation. And then oftentimes what they will do is afterward, you know, they'll pay you for your participation. So that oftentimes, not always, but oftentimes comes in the form of a check that's mailed out to you, you know, that you get in the mail. Some studies will use like an Amazon gift card and maybe they'll give it to you there, but most studies will actually, you know, send a check out to you for your.
So Mark, quick question, because this comes up a lot. Let's say I start the process.
Mm-hmm.
And then I go home and my friend Ray says, oh man, I wouldn't do that if I was you. And then I call and say, I changed my mind. Am I in any kind of trouble or something?
Absolutely, 1000% no. You can be in the machine and you can think about the conversation you had with Ray, and you start to say, you know what, I think he's right. I want to get out right now. Press a button, you're out, you're gone. That's it. No questions asked. This is completely voluntary. If anyone does that to you and gives you a problem, come talk to us, because they should not be doing that. That's totally wrong. You have the right to say no at any time.
So Mark, I told you when we first met about talking about this night, when I say what I'm about to say, you're going to go, damn, that was quick. We've got less than 5 minutes to go.
Wow. That was quick.
So, I mean, it's always a fun time. One more time, if I want to reach you, what's the phone number to the clinic?
Yep. So it's 617-726-1728.
All right. All right. I'll make sure I don't give that to Ray.
I want to meet Ray right now. Is Ray real, an actual person?
Actually, I do have a friend named Ray.
Ray. All right.
Who's very opinionated.
Okay.
So Mark, I want to give you the last word.
Excuse me. This is Shugi. I have put in the chat, Dr. Mark, do they have an open machine for the MRI test? Because for those that have claustrophobia, so do they have?
Not too many, although I think one of I know that we once looked into that, because I think one of our sites does have that. So we're kind of working on that. But unfortunately, most of our machines aren't. Most of the machines that we would use for research purposes, it's a great question. And we get this, you know, for research and clinical, and it's a problem if you have claustrophobia. There's nothing, you know, it's really tough to be in the machine. But Shugi, unfortunately, most of ours don't have the open MRI But we are working on it to try and get that for people that are, claustrophobic.
All right. So Shiggy, I
Thank you.
apologize. I missed you in the chat. So Mark, this is a question I ask everybody. If there's one thing you want folks to walk away with, what's that one thing you want them to remember about this amazing conversation?
I think the one thing is we can't do this without your help. I honestly, like I have, there's this one study I have now, actually two studies that I have going on now. And the biggest problem is not having people. It's not anything else. It's not like, believe it or not, it's not like the funding. We have the money that the NIH gave us, the National Institutes of Health. We have the personnel. We have great personnel, much smarter than me, helping out with all the analysis and everything. And the problem for these two particular studies is the people. We just lack the people. So we can't learn about these diseases without doing the research, and every last bit of research that we do is helpful. And we also want to do it in different populations. We don't want the research findings that we have to just represent one, part of human beings and not everybody else. And that's something that we care a lot about. And that's something that the country and the National Institute of Health cares a lot about. They're very take that very, very seriously. So as they should. And so, yeah, we need people like you, and that's like the most important thing is if you can help it, it would be really great.
All right, Mark, I want to thank you for hanging out with us. Like I said, man, you crushed it. You crushed it.
Thank you.
And I want to say to the UCB family, we're coming back November 14th for our last partner night of the year, and the topic is going to be getting ready for the holidays with a loved one who's living with dementia. Come hang out with us. And Siobhan, I'm not sure if I'm handing it off to you, but I'm gonna say, like I always say, everybody else, I'll see you around the neighborhood. I'm done. Siobhan, are we done?
Oh, wait a minute. We almost, hold on. I'm having tech issues. Give me a minute. I'm trying to pin myself. Hold on one second. Okay, there we go. Having little tech issues over here. But as always, I might put in the chat that we are going to try our best to get any questions answered that was not answered. So to make sure that you get your question answered by someone. And knowing Mike, he'll come back and do a table talk on that question. So more than likely you will get your question answered. And all the links have been saved in the Facebook chat in the comment section. So I dropped the link several times inside the chat box. Please make sure that you are going back and getting that information as well. I put all the links for the survey there as well, for the Madrix crew research study information, all in the Facebook chat. I'm sorry, I'm trying to say all this, not talk too fast. I know Melania is like, she's been going for 2 hours straight. So with that being said, I want to thank the Madrix team for coming with us tonight for this great information. I want to thank all the Piolas that came tonight. There was like 8 of y'all here tonight. Mark, I appreciate your expertise bringing this information to us. I'm one of the people that is afraid of an MRI. They have to like darn in and put me to go into that machine, especially if it's head first.
Yeah.
Try with the music. You say, "Oh, we got music now." It doesn't work.
Yeah.
It doesn't make it any better. But don't forget, guys, your health is your wealth. Please make sure you're getting your regular checkups. You're going to see your doctors. If you feel something is not right, you feel something's off, your body, make sure you reach out to your doctor. Don't call your friend and say, "Girl, I don't feel right. What should I do?" Even though that's the first thing we usually do, we need you to call your doctor, check in with a nurse, or call Mike. Mike will tell you to go to the doctor. So just go. And we appreciate that. All of my network coordinators, I appreciate you for all the work that you've done tonight. Melania, I thank you for all your work tonight translating. Of course, shout out to Mom, who's already gone. Springfield, thank you for joining. But I cannot forget to shout out my UCB crew. Boston, I love you. Without you, there would be no me. You guys make it worth my while. You make this job fun. You make this job wanting me to get up every day, even though I'd be so tired to come and do it again. So I appreciate you.
but I'm gonna give you a chance to come off of mute and say goodnight.
Good night.
Good night,
Night,
Shavana. We
everyone. Good
love
night,
you.
Siobhan.
Thank you,
Everybody,
Mike.
bye.
Thank you, Mark.
Good night. Thank
Oh, have
you.
a great
It was
night.
awesome. It was
Thank you.
beautiful.
Everyone.
Good
Hey,
night.
Sharina. Thank you.
Good night.
Hey,
Good
Lisa.
night, everyone. Stay blessed.
Take care.
Good night.
Forget about it. I love you. Bye.
Here,
Love you
bye.
too.
Love bars.